To our board meeting here in Wakefield today for the board of NHS West Yorkshire Integrated Care Board. Thank you for everybody around the table for giving your time today to support our work as NHS West Yorkshire and our overall health and care partnership, and also to people who have joined us today in person to observe the meeting, and also for anyone who's watching online on the live broadcast or on record afterwards. As NHS West Yorkshire, we work as an integrated care board. We're one of 42 in the country. We have 4 clear purposes around tackling variation in care, improving access and tackling inequalities, making sure we're using our resources wisely, and also making sure we're contributing to social and economic development in our communities. I hope what you can see, again, as our board meeting shows you, the ways in which we are trying to address those key points and show our progress. I think it'd be remiss of me not to say that there have been a lot of changes in the NHS, particularly with announcements nationally on Thursday last week of the changes with NHS England being absorbed into the Department of Health and Social Care for integrated care boards, including ourselves being required to make cuts and changes, and also continuing requirements, as we know, and colleagues around the table are aware of, increasing our productivity and making sure that we are delivering quality, safe services as always. For people watching the meeting now, we had a board meeting in private this morning due to particular sensitive issues or items or information, and I want to thank colleagues around the table for the robust discussion we had this morning on our planning for the 25-26 financial year, which begins on the 1st of April. So, first of all, I wanted to go round the table so that everyone around the table, those watching here in person and those watching online, know who's in the room. And just a reminder to colleagues, later on in the meeting, because we are together for a few hours, please introduce yourself. It's really helpful for people watching the meeting to know who you are and the roles that you play in our health and care system. Anthony, I'm going to ask you to start us off if you would. Thank you.
Afternoon, everybody. I'm Anthony Keeley. I'm the ICB Director leading on organisational change and review of our place partnerships.
Has it done it? Yeah. Awesome. Thank you. Tony Cook, Chief Officer Health Partnerships in Leeds, substituting for Ed Whiting, Chief Executive.
Neil Smurthwaite, Deputy Place Lead for Calderdale, substitute for Robin Tullingham.
Jane Madeley, Non-Executive Member of the Board.
Kim Shuttler, Lead for the Voluntary Community and Social Enterprise Sector. Victoria Valens, Deputy Chief Executive from Locala, deputising for Karen Jackson, who represents the Community Collaborative.
Richard Vautry, representing Primary Medical Services.
Carol McKenna, I'm Place Lead for Kirklees.
Hello, I'm Brendan Brown. I'm the Chief Executive representing the acute sector for West Yorkshire.
Hello, I'm Kate Sims. I'm the Director of People for the West Yorkshire ICB.
Good afternoon, everyone. My name is Shaukat Ali Khan. I'm the Chief Digital and Information Officer for the West Yorkshire ICB.
Hello, and I'm Lou Auger. I'm the Interim Director for Planning and Performance for West Yorkshire ICB.
Good afternoon, everyone. Majid Hussain, Non-Exec Member of the ICB.
Hi, everyone. Amy Willett, Head of Corporate Governance for West Yorkshire ICB.
Hello, Laura Ellis, Director of Corporate Affairs for West Yorkshire ICB.
Hello, my name's Rob. I'm the Chief Executive of NHS West Yorkshire.
Hello everyone, Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Exec for West Yorkshire ICB.
Hi everyone, I'm Adrian North, I'm the Deputy Director of Finance for the ICB, and I'm here covering for Jonathan Webb today, who's the Director of Finance.
Afternoon everyone, I'm Nanshu Chatterjee, Non-Exec Member for the Board.
Hi, I'm Hannah Davis, I'm Chief Exec of Health Watch Leeds, and I'm here on behalf of the 6 local Health Watch working across West Yorkshire.
Hi everyone, my name is James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board.
Hi everyone, I'm Mel Brown. I'm the Place Lead for Wakefield District. Lovely to meet you all.
Afternoon everyone, I'm Sarah Munro, Chief Exec Leeds and York Partnership Trust, and I'm here as the Sector Lead for Mental Health, Learning Disability and Autism.
Hi, Therese Patton. I am Place Lead for Bradford District and Craven Place.
Hi, I'm Tim Riley. I'm the Place Lead for the City of Leeds.
Hi, I'm Phil Hubbard. I'm the Director of Nursing and Quality for Bradford Place, but representing Bev Geary, who's the Director of Nursing and Quality for the ICB.
Hello everyone, I'm Victoria Eaton. I'm the Director of Public Health for Leeds, and I'm here on behalf of all 5 Directors of Public Health across West Yorkshire.
Hello everyone, my name is Fatima Khan Shah and I am the West Yorkshire Inclusivity Champion, which is a shared role between NHS West Yorkshire and the West Yorkshire Combined Authority.
Good afternoon, I'm Debbie Gibson. I'm the Director of Midwifery for West Yorkshire ICB and the Programme Lead for the local maternity neonatal system.
Hi, I'm Jo Butterfield. I'm the Programme Manager on the West Yorkshire Mental Health, Learning Disability and Autism Programme.
Hi, my name is Sarah Smith. I'm Deputy Director for Population Health at West Yorkshire ICB.
Thank you very much, colleagues. And hello, my name's Cathy Elliott. I am Chair of NHS West Yorkshire and Deputy Chair of our Health and Care Partnership. Colleagues, thank you for introducing yourselves. It's really helpful. And if anyone's wondering why we're using microphones in this room, it really helps with the live stream as well as the recording of this meeting as well. So thank you. And as you can hear, if you're experiencing our meeting for the first time, the breadth and depth of experience, and I'm really pleased that we've got so much representation, particularly from outside of the NHS as well as within, and particularly our public health colleagues who've joined us today. So this meeting marks the end, coming to the end of our financial year in the 24-25. I want to thank everybody for huge effort that has gone on, whether it's looking at the quality of our services, transformation and innovative ways of working, or particularly in working on productivity and efficiency work within the NHS. This meeting also is the last one where we'll be looking at a focus on topic on reducing health inequalities, which is why we have Debbie and Jane and Sarah with us today, and we'll be looking at how we can work together to reduce health inequalities in maternity services for local mums and their families. This will be then linked to a report that we'll have at our June board meeting in looking at maternity services across our whole system and the quality improvement taking place, which our colleague Beverly Geary, ICB Director of Nursing, will lead on. We note that it is our colleague Carol McKenna's last board meeting. She will be retiring in a matter of days, and just before the start of this meeting we said thank you and we said farewell to her. But thank you, Carol, so much for your leadership in Kirklees and the many changes and your contribution to the system as well. And we wish your colleague Vicky Dutchburn every success as she takes on the interim place lead role. But thank you, Carol. We have around the table today a number of people who are deputising, as you heard on the introductions, but I'm just going to ask my colleague Laura just to confirm those so we can put them into the minutes.
Thank you, yes. So today, just running through the apologies and deputising arrangements. We have apologies from Nadra Mirza, Robin Tuddenham and Neil Smurthwaite is deputising, Beverly Geary, Phil Hubbard is deputising, Mariana Pexton and Tony Cook is deputising, Jonathan Webb, Adrian North deputising, Karen Jackson, Victoria Valance deputising, and Majid has also informed us they'll be leaving at about 3:30. Thank you.
Thank you very much. I'm just going to go through the sort of standard business that we have at the start of our board meetings. So can I look around the table and ask if there are any declarations of interest today in relation to today's agenda? No. Okay. Again, board members, you'll be sick of hearing me say this, but a reminder, please keep your declarations of interest up to date on the online portal. It's a public record and it is available for members of the public and stakeholders to view, and please keep that up to date. Thank you. We now have the minutes of our last meeting. If you remember, we gathered together on the 17th of December in Leeds. This is about us taking our board meetings and activities out onto the road across the 5 places that we serve in West Yorkshire. Colleagues, first of all, is that an accurate record of our discussion that day? Yep, I can see nods around the table. Thank you. Laura, would you just take us through the action log just to make sure we're on top of things that we've agreed on?
Thank you. Yes, there's two actions on the action log. The first one, which relates to the digital strategy, is not yet due. We are expecting to bring that to a future board meeting. And the second action related to the board assurance framework, and that has been included in the work plan for next year. So we are proposing that we close that action. Thank you.
Great. From that last meeting, our focus on session, which was on our role on how we reduce health inequalities, particularly around the themes of frailty for older people and ensuring ageing well in West Yorkshire. Through all these 4 topics we've had over 24-25, I'm grateful to Sarah Smith and other colleagues who are going to work with us at our next board development session just to reflect on what we've achieved so far and then also what we need to do next. I also note for our April board development session, we'll be looking at our digital strategy with Shaukat and AC as well, which will then come into our series of board meetings and discussions for 25-26 as well. I thank you. Okay, so if we move on, we have an urgent decision to note. As you know, from time to time, we take urgent decisions to make sure that we can have our governance in an enabling way to support our work together. Laura, would you just give an overview of the urgent decision, and then I just need to ratify it with you as board members.
Thank you. The urgent decision relates to West Yorkshire procurement of an all-age service for the assessment, diagnosis and treatment of autism spectrum disorder and ADHD. It was around the procurement process in terms of the urgent decision. There was discussion at the Transformation Committee, and then we took yourself, Kathy, and Rob, along with AC as a non-executive member, took the decision.
Thank you. And we noted at that discussion that this had already been through our West Yorkshire ICB Transformation Committee for consideration as well. Colleagues, are you happy to ratify that decision? Yeah. Okay. And if anyone's interested in that information, it is available online. You can click onto that document to find out more about the decision around those services. Okay, so we now move on to item 13, which are public questions. We take public questions in 24 hours in advance of our meetings in relation to that day's agenda and for our meetings that take place on a quarterly basis. So we've had 3 questions submitted in advance. We note that we've had one received a matter of minutes ago, which we will commit to providing a response to, but we can't do that today. So Laura, I'm going to hand over to you, and I know you're going to work with colleagues on providing responses. Thank you.
Thank you, yes. I'll go through each question in turn. I'll read out the question and then I'll pass to one of the board colleagues to be able to respond. So the first question is received from Usman Khan. Are there any plans to practically develop bespoke paid leadership positions and careers for people with lived experience of health inequalities and difficulties to help lived experience have an equal value in decision making? If there aren't, how else will you help lived experience to be equal in decision making? And I'm going to pass to Kate Sims, our Director of People, to respond.
Thanks, Laura. I think it's important firstly to say that there is a detailed response that we'll have on the website with regards to some of the pieces that I will mention in a moment, so just to encourage people to look at that. Across West Yorkshire, we are clear that involving our local communities, people, staff, of course, and our partnerships is vitally important, and lived experience and using what people have told us is central to many of our discussions. There are many mechanisms, in place for people to share their thoughts and views and also to be engaged in those wider responses. And my colleague who's behind me, Paul Hemingway, our Head of Communications, you will see on our website many ways in which you can be involved. As a system, we also recognise for all of us the value of bringing our own lived experience into our working roles for all of us who work across the partnership. And some of the progressive initiatives that we've developed in West Yorkshire and have been implemented include our inclusive recruitment toolkit, which again, there will be details available. That's very much bringing together best practice around this. Our West Yorkshire Fellowship Programme, which is aimed absolutely at increasing the diversity of our leadership, and particularly from our colleagues from ethnically diverse communities. And we've seen a significant positive result of over 75% of colleagues who've completed that programme have seen their careers progress. And it goes without saying our West Yorkshire Inclusivity Champion, a joint appointment between the Mayor of West Yorkshire and the ICB. Fatima attends this board as a strategic advisor, working closely with all of us as leaders and communities and providing that expert advice in relation to tackling disparities. So I'll close by saying that there are many ways that members of our communities can get involved, including, of course, through West Yorkshire Voice. More details will be available on the website, so thank you.
Thanks, Kate. Moving to our second question, which is from Dr. John Puntis. The Health Inequalities Maternity Deep Dive report identifies, among other things, migrant or asylum seeker status as a key risk factor. Undocumented women in some parts of the country have been charged as much as £14,000 for maternity care. This can act as a barrier to accessing care, together with the threat of data being shared with the Home Office. Can you tell me the number of foreign nationals with no recourse to public funds who have been charged for maternity care in each place-based partnership of the West Yorkshire ICB over the past 12 months? I'm going to pass to Ian Holmes, our Director of Strategy and Partnerships and Deputy Chief Executive, to respond. Thanks.
Yes, thanks, and thanks to Dr. Puntis for the question. And Dr. Puntis will recall that at our September meeting of the board, he asked a question about charging for overseas visitors and the impact that that would have on people accessing the care that they need. In that meeting, we explained that some people, some groups are exempt from charging, but the threat and the fear of being charged for services is sometimes can put people off accessing those services. We were also able to highlight some of the work that we've done through our health inclusion unit and as part of our ICSF sanctuary work to support people to understand the services that are available and how they can best access them. Now, the question that he's asked for this board meeting is quite specific, and we don't have those numbers to our fingertips. We haven't been able to get all of those in the last 24 hours. So what we'll do is we'll work with partners across the system and provide the information that he requires in terms of those specific numbers. Thank you.
Yes, we can put that onto the website afterwards so that there's a full response. Thanks, Ian. So our third question was also from Dr. John Puntis. Concerns have been raised by parents over possible high neonatal mortality at Leeds Infirmary and were taken up by the BBC. The response by Leeds Teaching Hospitals Trust on its website stated that an independent review comparing our figures in more detail with other specialist hospitals shows our neonatal mortality rate is within the expected range. This would be reassuring, except that the Trust has not made the findings of the independent review public and has declined to make relevant documents available following a Freedom of Information request. As a former Director of Neonatal Services, I am interested in seeing documentation supporting the statement made by Leeds Teaching Hospital Trust and ask now whether this could be acquired through the offices of the ICB. And I'm going to pass to Phil Hubbard, who's deputising for our Director of Nursing today. Thank you.
Thank you. So thank you for the question. And I think today we're focusing obviously on the health inequalities and tackling health inequalities around maternity services. And we anticipate that the report around service provision and quality improvement will come to the June board. But we obviously are answering the question around the Freedom to Information request for LTHFT, which is these teaching hospitals. So if we will review this and respond to you directly within the appropriate timescales.
Thank you, Laura. And then we have a fourth question, which we've received only very literally in the last half hour or so, but we will commit to respond to that afterwards as well. Okay. Thank you very much. And thank you to people who regularly ask questions or sometimes for the first time. This is really helpful to have this opportunity to share further information and aim to provide assurance to the public as well. Our next board meeting in June will undertake the same process again, that we will take questions in relation to that meeting's agenda up to 24 hours in advance. We also have our Integrated Care Partnership meeting, which is where the NHS comes together with the voluntary sector and local authorities and Mayor Braben and the Combined Authority. And for that meeting on the 1st of April, again, we will take questions from the public in relation to the agenda 24 hours in advance. Okay, thank you. And those two questions, as our colleagues appreciate, then takes us into our discussion on reducing health inequalities in maternity services and working with local women and their families. So thank you so much to Sarah, Jo and Debbie for joining us, and to Hannah and her colleagues at Healthwatch for providing the report today. So what you have is a report from our colleagues with a public health lens on how we can, as the ICB, in our commissioning role and our convening of health and care partnership, can work with partners and services to reduce health inequalities. We then, as usual, have a lens, an insight and intelligence from Healthwatch on what local people are telling them and how we can then align that. And there's always key messages that come from those Healthwatch reports, including about compassionate care and good communication. And there's also a film that I hope you've watched online, where I'm really grateful to the women who shared their stories, who are based in Leeds, about good care that they've received through maternity services and ways in which that can be improved. And that's available on our website as well. So I'm first of all going to hand to Sarah, Debbie and Jo to give some highlights from their reports. Then we'll go to Hannah in representing Healthwatch, and then we'll open it up to discussion. And as you know, colleagues, as we've looked at this over the last nearly 12 months or so, it's very much about your reflections on the good practice that already exists in our system, whether it's by places or providers or certain partnerships, but as well what you can pledge as health and care leaders to take away to make sure that there are improvements. So Sarah, over to you, and thanks again for taking on this brief for this financial year.
Thank you, Chair. And just in case of people who've joined the live stream, my name's Sarah Smith. I'm Deputy Director for Population Health at West Yorkshire ICB. And we really welcome this opportunity to come here for the fourth time this financial year and have this focus session on health inequalities. As per the last sessions, we are following a life course approach. And for today's paper, we're focused on maternity services and maternity care. Debbie and I are going to give a really quick overview of the paper, which we will take as read, and then, as Cathy said, we'll invite questions and discussion following information from Healthwatch. So, as with the other reports, this report will focus on what's within specifically the role of the Integrated Care Board as part of the wider health and care system. So we acknowledge outcomes in maternity services and maternity care fall within the whole health and care system and are impacted on by determinants of health also. But we're really going to focus today on things that are within the gift of the Integrated Care Board. We're going to focus in on three areas. And those three areas are what we can do as a health and care system on modifiable risk factors, particularly looking at tobacco dependency. Focus on timely access to pathways, so any inequalities we see in the time in which people are accessing maternity services as part of their journey of care, and focus on perinatal mental health. So I'm just going to hand over to Debbie now, who's going to give a summary of those three areas.
So good afternoon. So I'm Debbie Gibson, the Director of Midwifery for the ICB. We've submitted quite an extensive report, and so the purpose now is just to give you some key highlights from that. And as you'll see from the report, it highlights the significant deprivation and diversity in West Yorkshire, all of which impacts health and outcomes for women and babies. There are, as Sarah said, multiple modifiable factors that can improve health outcomes, including smoking support, healthy weight and lifestyle, environmental and social factors. And there's much we can do to impact on this, and the paper includes examples of lots of ongoing work that's in progress and the positive impacts this has had. So there's been a significant investment in smoking cessation strategies over recent years, and this has led to a significant decrease in the number of women that are smoking at the time of birth. And we know that smoking does impact the outcome for both mother and for the unborn baby. We know that stillbirth rates are higher in the areas where they're most deprived, and there's been lots of extra support put in place for including increased continuity of care, longer appointments, additional support for women that are new to the country, midwifery teams that are targeted those most vulnerable women who have reduced caseloads, and enabling them to have increased time with women and to build those relationships and provide additional support for their health needs. There's also targeted support for women who don't have fixed homes to live in, and there's been some implementation of women health hubs where different professionals can come together and work together to provide the best care for women and their families. And there's been an example of compassionate support for women with raised BMI. Been defining some principles of supported conversations, the principles of which could be adapted for any health outcome. With regard to our mental health work, the mental health is a significant risk factor in maternity care. and providing the right support and information early in pregnancy is important in enabling the best outcomes. The newly established PATH service implemented an inclusive approach to its setup, being aware that higher than average incidence of baby loss occurs in populations of high deprivation and global majority. There are some barriers, There are some barriers to accessing maternal mental health services, and those can be multifactorial. There can be things such as limited awareness, stigma around that, fear of child removal. There can be cultural barriers and just access to services. There's also, within the paper, we highlighted elements around access to services, and we know that our most vulnerable women have greater difficulty in accessing services, and there's been multiple initiatives to support that. Those include the early booking campaign that was co-produced with local women representing diverse communities and aims to promote early engagement with maternity care. There's been examples of group antenatal care that decreases isolation and provides peer support and raises awareness of the health support that's available, particularly for perinatal mental health support, enables opportunities to provide education and a safe space to discuss how the feeling and signposting for additional benefits and services. There's also organisations such as maternity circles that have been set up where they provide pregnancy support, information about what to expect in pregnancy, providing support from professionals, and as well as some specialist support for dads and partners. There's been some initiatives in some places called the maternity befrienders roles, and their roles to support women particularly that are new to the country and migrant women, and they have initiatives such as maternal journaling, providing a listening ear, and can provide prompts to those women of how to access services and when to access services. They also provide group antenatal education, which enables them to have that support together. So our local dashboard data of 2024 is actually suggesting a decline in perinatal mortality rate at the moment, which is really positive to see. And we hope that with the ongoing initiatives like the one that have been described in the paper, as well as all the other initiatives, we will continue to see a decline and will continue to positively influence outcomes for women, babies and families in West Yorkshire. And by addressing the modifiable risk factors and including preconception care. Do you want to bring it into that?
Thank you, Debbie. So just to summarise in terms of the recommendations, there are 4 themes really we thought were coming out from the report, both in terms of the progress that's been made so far, in terms of targeted interventions to reduce inequalities and the intelligence that we're looking at as well. So the 4 areas that the board's been asked to consider specifically is to note the progress around the tobacco dependency services in West Yorkshire and the great work that's been done for implementation there, and to continue to support that. And note the progress that's been made around reduction in smoking at time of delivery rates as well. To support improvement interventions to reduce inequalities for timely access to that time of booking that Debbie was talking about, particularly in relation to deprivation, for areas of high ethnic diversity, and also for women and families who are new to the country. To continue to work with communities to support access to perinatal mental health services, to raise awareness of these services in targeted communities, and make sure they're delivered in a culturally sensitive way as well. And finally, to support alignment with this report and the findings of the Race Equity Review. So that came out really strongly for the West Yorkshire Race Equity Review from our VCC Voices panel, which is a panel of people who represent voluntary and community sector organisations who work predominantly with ethnic minority communities. We want to support alignment with the Race Equity Review and the focus on reducing inequalities in relation to ethnicity as well. So they were the 4 recommendation areas.
Great.
Thank you, Chair.
Sarah and Debbie, thank you so much. It was a great summary for us and really clear what you're asking for the boards. And I know, Sarah, we've worked on this in trying to what do you ask of the Commissioner and the convener of the partnership in this work, and how we're really specific on this. Fata, I'm sure we'll hear from you in a moment about that reference to the strategy, the fairness and equity strategy. But I want to go to Hannah first. Hannah, would you introduce yourself and
colleagues will see that there is a Healthwatch intelligence report which brings the voice of women across West Yorkshire into this conversation.
Yeah, thank you, Cathy. My name's Hannah. I'm Chief Exec at Healthwatch Leeds, but as I say, I'm here on behalf of the 6 local Healthwatch working across West Yorkshire. This report, as Cathy said, for every meeting we produce a report that brings together people's experiences across West Yorkshire. This isn't just Healthwatch intelligence though, this is from ICB and NHS, Insight colleagues, conversations with the 5 maternity and neonatal voice partnerships and our West Yorkshire Voice members as well, so Leeds Gate, Gypsy and Traveller Organisation and the Yorkshire and Humber Perinatal Mental Health Co-Production Group. So many thanks to all those organisations that have fed into this report. The report is a summary of all those messages that we've heard from people. We're particularly focused on health inequalities around mental health support before, during and after pregnancy, smoking cessation services in maternity, support before pregnancy and inequalities in access to maternity pathways, including time of booking. As Cathy said, we sent out a video before the meeting. I don't know if people had a chance to watch that, but that was a really good video that was produced by Leeds Teaching Hospital, which was a really brilliant conversation to watch from people who experienced mental health services, maternity services, which sort of reflects the sort of findings of the report as well. I won't go through all the report in terms of the findings. I'm hoping people have read it, but there are some really important points to highlight and the recommendations that we make, which actually align themselves really well, I think, to the public health report as well. The first one is there is a lot of good practice going on across West Yorkshire, and in the report it highlights some of those as well as the public health report. But the first one is learn from and mainstream successful delivery models of holistic care, such as doulas, maternity circles, maternal journal and targeted midwifery services that have had proven benefits for people at risk of health inequalities. So really positively, we've got really good examples of how to do this right in terms of access for people experiencing inequalities. Number 2 is recognise current cultural bias in systems and services and take steps to address this. One way this can be done is by making sure that we keep listening to the voices of individuals and communities that are identified as most at risk of experiencing health inequalities. We do have brilliant local maternity voices partnerships, but these need to be properly resourced to enable them to engage effectively and listen to these groups of people and on an ongoing basis. We also recommend that more work is done specifically to understand the experiences of the groups of people identified in Section C, which is the voices missing from this report. The third recommendation is that all healthcare staff should be provided with training in reflective practice to improve their cultural humility of the different communities they work with, as well as understanding any biases or stereotypes that they may hold. This also needs to be built into education of healthcare professionals from the outset. Number 4, work needs to continue to improve representation in the maternity workforce. Number 5, work with communities to continue raising awareness of things such as perinatal mental health, maternal health and risks, and support that is available in a culture-sensitive way. Number 6, there needs to be better training in primary care to raise awareness about perinatal mental health, including upskilling staff to have more in-depth conversations about well-being and about the potential risks of missed opportunities. It would be helpful for training to include elements of lived experience. Number 7, communication is important. Services and staff should proactively use inclusive language and listen to and take concerns seriously. Conversations need to be trauma-informed, compassionate and sensitive to cultural issues and stigma. Number 8, information needs to always be easy to understand and accessible and in different formats, pictorial, video, different languages. It also needs to be targeted in a way that is helpful and reassuring to people who may not be familiar with the UK health system. Number 9, we need to get better at sensitive collection of demographic data in maternity services, complaints and maternity and neonatal voices partnerships, including around sexuality and gender identity. And number 10, people's experiences massively affect their trust and future engagement in the health system, and consequently their health outcomes. The impact on people of not having a good experience can be greater for groups of people who may already face more barriers in accessing services, have faced discrimination or have less power in society. So we really welcome our report and going forward to the West Yorkshire Quality Committee, but also to local place committees as well.
Thank you very much, Hannah. And there's a lot of honesty in that report as well on things that go well and outstanding services actually across West Yorkshire, but also some really tough things to hear that I hope in sort of sharing them through your report will be very helpful for people to take on board. And I agree with you. I'd really encourage the report, the Health Watch report and the Public Health report to be taken into place committee discussions, as well as our provider collaboratives across West Yorkshire as well. So I suppose to reflect one of the key messages in the report, we need to aim to eliminate health inequalities and ensure that women have access to the services and support that they need. If you've watched the film, you'll know that the women there were talking about how they want their opinion to matter. They want to be a participant in their birth, an active participant in their birth, and feel supportive. And they did cite good quality care that they wanted to see across West Yorkshire. So, as we said, this is a focus on reducing health inequalities through maternity services, and then we'll pick up quality of service delivery in the NHS at our next meeting. So I'm looking around the table to see if anyone would like to start us off on the conversation. And Fatima, I'm looking to you as our inclusivity champion, particularly as the reference to the fairness and equity strategy that we've recently launched.
Thank you, Chair. Hello, everyone. Again, my name is Fatima Khan Shah and I'm the West Yorkshire Inclusivity Champion. So you may have heard that we've announced a new strategy called the Equity and Fairness Strategy. And if you've not heard about it, where have you been? Because it's been everywhere. And the reason why it's really important right now in a world where people are moving away from equality, diversity and inclusion initiatives is that we in West Yorkshire have taken it to the next level. So we've recognised that actually equality and diverse initiatives can only take us so far. But to truly create an equitable society, we need to focus on social justice and fairness, which is what exactly this strategy delivers. It also builds on a sort of a triumvirate of 4 areas. One is being very much led by data. So we did a lot of analysis on the health inequalities data. Thank you, Sarah Smith. A lot of work done on the staff experience survey. Thank you to Kate for that. And also a real look at what are the things that we must do, but also what is in keeping with the values of West Yorkshire. But the most important factor was the experience and feedback from the people of West Yorkshire, of which we're very grateful. Thank you to Paul and his comms team for facilitating that. We have 10 strategic objectives within the Equity and Fairness Strategy because we want it to be achievable and realistic, as Fatima always says, under promise, over deliver. And they all sort of overlap into sort of 4 specific areas. One is the relationship between the communities and people that are accessing our services, very much in line with this report, about really focusing on the experience and outcomes of people using our services. Another element is ensuring that our workforce is not only reflective of West Yorkshire, but they're able to fulfil their potential and feel like that they can be both able to speak up on issues relating to quality, but also more importantly feel able to support initiatives to improve quality outcomes for our population. And also there is a real massive focus on sharing the story with our communities of how we're making a difference, because there's no point putting the work in if nobody knows about it. In specifically referencing the Donna Kinnair review, which was an evaluation that took place at the back end of last year, building on the initial review undertaken by Professor Dame Donna Kinnair in 2020, it focused on 4 specific areas which were highlighted by an independent panel of reviewers. That was specifically looking on safe access to work, and that is both physical and psychological safety. There was also reference to the leadership of our workforce, the way in which we design and deliver our services, and also a deep dive led by the data on the experiences of people utilising our mental health services, and that focused specifically on black men and also South Asian women. During the evaluation of the review, the VCSE panel, which is an independent panel that was created at the time of the initial review, highlighted some concerns regarding the data of experiences and outcomes of people utilising maternity services. As a consequence of that, there was a recommendation from both that panel and Professor Dame Donna Kinnair to ensure that as we're aligning our strategic objectives, one of which is the access and experience of people using health services, that we do a specific focus on maternity, which is why we've suggested that recommendation. And for those of you that haven't seen the Equity and Fairness Strategy, do check it out, and we're hoping to have a podcast about it quite soon. Couldn't ignore the opportunity to have a quick plug. Thank you.
Thank you very much, Fatima. And I know through our partnership board that met in January, you were asking all providers within the NHS, as well as other partners from local authorities and the voluntary community and social enterprise sector, to respond to that as well. So I know, Majid, you want to come in, and I'd really want to invite comments and questions around the table. I wanted Brendan on behalf of the Acute Provider Collaborative, Victoria and Sarah, I'd welcome your thoughts on the area of fuel poverty here, which comes through around unstable housing housing or poor quality housing as well. And James. Okay, so Majid, we'll start with you. Thank you
very much. So I'm Majid Hussain, non-exec member, and have interest in inequality. So 2 or 3 things. So the first one, really good to hear about all the programs that you've highlighted in the report, and it'd be good to sort of get a feel, not today, but at some point, in terms of which ones have had the greatest impact, because we are now heading in a difficult period with money, so it's really important to sort of get a good feel on that. Second thing is in terms of the sort of broader health inequalities that are caused by housing, income, diet, deprivation, etc., is how we are using these reports to get more into that space. The third point, there's a lot of back to basics that have come out of the report, what Hannah spoke about, and we're still talking about people not feeling involved or engaged in their sort of care or treatment, lack of awareness about services, etc. Language, digital access is still an issue, representational workforce, etc. These are not unique to maternity services, so how can we use this opportunity to tackle these back to basics issues which sort of keep occurring when we hear sort of feedback from different reports and communities, things like building trust, cultural competence, etc. So I think really important that we pick these up. They don't all explicitly feature in the 4 recommendations, but I'm sure they can be sort of slotted in, and it's important that we don't lose them. And then how are we going to make sure, for example, Shoka spoke earlier on about digital strategy, is how can we make sure that what we hear from here is embedded into that strategy. And Kate obviously doing a lot of work around the people strategy and representation, so the issues are mainstreamed and embedded in broader strategies, including Fatima's strategy that she just mentioned. Otherwise, it's going to be a piecemeal approach here and then another piecemeal approach there, and we're not going to have the impact that we need in this area and many other areas. Thank you.
Thank you very much, Majid. And you've referenced a lot of strategies, but also what we do in West Yorkshire as well as make sure they're implemented, make sure they're being delivered, and then tracking the success of those and learning from that as well. Thank you. Sarah, Joe and Debbie, I'm just going to carry on taking a few more comments, and then maybe you could take take them as grouped. We'll go to James, then to Rob, and then we'll come back to our colleagues.
Yeah, no, thank you, Chair, and thank you, colleagues, for your presentation. My name is James Thomas. I'm the Medical Director for West Yorkshire Integrated Care Board. 2 points, really, and there are positives, and it sort of builds on from what Madge has just been saying there, really. I suppose I just wanted to highlight, and it was obviously highlighted in the report there, about our smoking censation and the success, and I think it's a significant success in terms of the reduction we've had there from 13.1% down in 2020 to 5.8%, and I think that's quite significant. The impact that's going to have not only for the mother but for the unborn child, and actually going on in terms of family life there. And I suppose it's just understanding the how can we build on that for the wider population, because there's something significant that's happened there, and how do we enable that in the wider population in terms of smoking cessation there, and just kind of feeds into kind of our prevention work there. The second point, I think, comes back to also again about communication. I suppose I just wanted to kind of highlight again, recently at our system quality committee, we discussed and heard about some of the translation services that are happening within our maternity services locally, and actually some of the real kind of quality improvement aspects have taken place for those translation services, enable better communication, better for staff, better for the individual there within our maternity services there. And again, there's something about kind of sharing that. And you asked earlier, what's our role as a commissioner? Our role as a commissioner is about sharing that good practice. So sharing that good practice with smoking cessation, I think also sharing the good practice with the translating services, and how we utilise that, not just within the maternity services, but wider within our services there. But Some good news stories there, but some challenges to the system in terms of how we kind of spread that and get the real benefit from that. But thank you, colleagues.
Thank you. Then we'll hear from Rob, and then Sarah will come back to you.
Like James, I'd like to start with, the real positives in this paper on some things that are really difficult to achieve. And I was really struck by the reduction in smoking rates in pregnancy from 13.1 to 5.8% of mothers, which is an incredible achievement. And I was really struck by the fact that the targeted smoking cessation services for the lowest decile of the population, where quit rates are much lower, was profoundly positive, and I presume is behind some of that reduction. So I think that demonstrates in action. People ask me quite a lot, well, what do you even do about health inequalities then? How do you target and do something about it? Well, you got some evidence here of this is one of our 10 big ambitions. This is one of the things that we've targeted the interventions at people who require the more support to quit, informed by lived experience directly from individuals that will help. So I thought that was worth noting, for those who think this is all too difficult. Well, there are examples where you can make a difference. I was also really struck by the reduction in stillbirths over that period, which again is significant, and the narrowing of the gap on stillbirths. That's the way I read it. So there's been a reduction in the overall numbers, or the rates of stillbirths, and there's been a reduction in the gap in inequalities within the population around that rate of stillbirths, though stillbirths are still higher amongst people in deprived communities. So again, it's really good work that we're all doing in this space. I was, though, struck by the infant mortality numbers, and it'd be useful just to understand neonatal mortality. Why we think we're seeing that reduction in stillbirths, but we have a higher rate of neonatal deaths. And I was also struck by the maternal mortality rate. So there's a question about two questions really. What do we think we're seeing there? Big difference between stillbirths and neonatal mortality, and then do you just want to say a bit about intersectionality? So what's the biggest driver of neonatal mortality, maternal mortality, stillbirths? Is it poverty? Is it ethnicity? Because if you look at ethnicity and poverty, very closely linked in West Yorkshire. Or is there a multiplicative factor because of that intersectionality?
Thank you, Rob. That's really helpful. So I think Sarah, Jo, Debbie and Victoria, are you going to contribute? Or no? Yes. Yes. Victoria, over to you. Would you introduce yourself?
So just while I remember, and is there a link to the perinatal data that we've got that shows that 4 to 15% difference in referrals? Because the graph certainly looks like poorer parts of West Yorkshire less likely to be referred for perinatal mental health.
Thank you, Chair. Is that working? Yeah, thank you. Just a couple of comments, if I may, and partly to build on the comments that Rob's just made. So the first comment is very much support the 4 areas of recommendation, and we know that the single most important driver of poor health and the single biggest intervention we can focus around is around smoking and tobacco generally, but also for this group. So obviously that's really important as the number 1 recommendation. But to some of the points that Rob's made there, the data is really helpful around that, around the role in tobacco control in reducing inequality. So we know poverty, and again to Rob's question, poverty is the biggest driver of poor health apart from age. And obviously the poverty dimension absolutely plays out through all the data in this work. Now, we know that women in IMD1 are 6 times more likely to smoke than people in the most affluent decile. So that focus on tobacco control really does drive down inequalities that are relating to poverty. But if we look at the ethnicity breakdown, it's more prevalent in white groups. So even though it's critically important, it's not likely to play a great role in reducing the gaps in ethnicity inequality. So I guess it's just being very cited on that, and actually some of the other recommendations are going to be much more critical in that. Doesn't mean we don't do it, but it's that combination of poverty and ethnicity coming together, and some of these interventions will play into one rather than the other. So they're all important, but I think it's having clear expectations around what the outcomes will be by focusing on a particular intervention. And then briefly, there's been reference to how this work sits alongside the work that's happening in each place around some of those broader determinants of health. I think a colleague mentioned it over there. So just to assure the board, we are working really closely with Sarah and the team around the work that we do in local public health teams in each place, partly around that broader public health delivery, but also around those determinants of health, which would include anti-poverty strategies, housing strategy, etc. So happy to say more on that if that's helpful, but just assurance that that work absolutely is happening to join those things up. Thank you.
Thank you, Victoria, in representing public health on our board. That is really, really welcomed, and understanding the broader determinants of health and how we work together as a system, not just the NHS, on working on this together. Sarah Smith, is there anything you just want to reflect on before I go to the next group of comments?
Yeah, quite a bit to reflect on, so I'll keep it brief. I think overall, I think the focus here and what we heard last week around the focus on quality and productivity for ICBs, I think this conversation we have absolutely plays into this from an inequalities point of view. So the focus on inequalities and what we're hearing around quality of people's experiences. So in relation to cultural competence, people feeling heard, and having the right workforce that's representative of the population helps with that, but also training helps with that as well. So I think from a quality point of view, from a determinants of health point of view, I mean, Victoria touched on it, but I think we've got opportunities as well working with the combined authority and having joint roles there to influence a health and all policy approach and kind of bring to the fore some of this population health data in the combined authority. So that's something we can take away to do and kind of really drive home that life course approach. And we have opportunities within our hospital and health and care pathways as well. So there's a poverty toolkit that's about to be launched from the Office of Health Improvement and Disparities that Public Health Registrar's worked on. And that's got some really good points for trust to pick up actually around poverty and around housing that we could do well to implement in West Yorkshire. I think there's some really good opportunities with the digital and data strategy to influence from these reports, not just from this maternity report, but from the full year's worth of focus on sessions. And Showkat and I have linked up between that and said we'll work together on the development session, I think around digital inclusion specifically, but also around our population health management approach as a system, and how we use not just data but turn that into intelligence to inform decision making. And I think that comes on to the final point really that Rob was making around answering that question around the difference between stillbirth and neonatal mortality. It's not something, I don't know if Debbie does, that I know the answer to yet, but I think if we had better linked data that was linked to those demographics, that we could link to intersectionality, we could better answer some of those questions and better target services. And finally, I mean, Victoria's covered the smoking point, but just to say we've had similar successes with smoking cessation in inpatient pathways, mental health inpatient pathways, and an emergency department trial within Calderdale Huddersfield Foundation Trust as well. And the reason we focused on that as a system was we see more people from the most deprived decile turn up at the emergency department. So that's why as a system we said actually we need targeted smoking cessation services in there. So that's not something that's done nationally, but something we decided to focus on in West Yorkshire. So just a bit of an opportunity to mention that as well. So I said lots of reflections, but I'll stop for now.
Great. Thank you, Sarah. That's really helpful. And as colleagues know around the table in the NHS, our planning guidance, the way in which we work together and deliver in 25-26, particularly talks about the role of integrated care boards and strategic commissioning. And what you're just talking through there is a really great example of that, how you understand your population and deliver the services. And I know colleagues around the table are working on this through their place partnerships in making sure that they truly and better understand their populations as well to deliver the right kind of services collectively. We've now got comments and questions. Brendan, Sarah Monroe, AC, Richard and Kate. I really wanted to ask you to talk about the workforce piece that's come up a couple of times also. So first of all, we'll go to Brendan. Would you introduce yourself?
Hello, I'm still Brendan Brown, representing the acute sector. I really welcome this report, and I think as representing the acute and integrated providers who deliver elements of maternity services, I think it was great to see the report that spoke with honesty about the real experience of the women we are serving. I think it's easy to focus on the regulatory standards and statistics, but it's more than that. I think the report and some of the negative experiences spoke to actually is the model, the national model that we're delivering still patriarchal in its approach. How are we so disconnected at points through a woman's pregnancy? So for me, I think we need to focus on the statistics. That's absolutely right. That's how we monitor improvements, but we shouldn't lose sight of some of the cultural elements that we've talked about, the choice, how we truly inform our women and families of what their experience could be. And we shouldn't lose sight of the compassion that we need to approach the whole pathway with. I think that gets lost in some of the narrative, not your narrative, but some of our narrative. We shouldn't lose sight of how do we deal with our communities compassionately. The other bit for me, and I wonder if it's slightly separate to what you've described, but I do think there's an area of focus on pregnancy loss and miscarriage that we should consider, because we talk about, sadly, stillbirths or neonatal deaths, and we talk about those often as statistics. They're not statistics, they're families' experiences and loss, but we should also talk about some of the post-conception pieces and the miscarriage and pregnancy loss. That might be for a future debate, but it's something we should consider.
Brendan, thank you very much, and I hope the West Yorkshire Association of Acute Trusts will find this report helpful to them in their work. We'll go then to Sarah Monroe, then AC, Richard, Kate, and then to Fatima. So Sarah.
Yeah, thank you. Sarah Monroe, Chief Exec, Leeds and York Partnership Trust. And I suppose it builds on the last point that Brendan made. It's great to see the inclusion of maternal mental health provision and perinatal mental health. Maternal is quite recent, and actually some of the women that service is aimed at is the very group that you're describing that have experienced previous loss and what that means in terms of their own mental health trauma and approach to future pregnancies. I think just to note with the beds for the mother and baby unit is currently 8, but it will expand in the next year. That's a regional service. And the one thing that's apparent, because we've got a lot of good examples referenced in there, and we see when you're part of that regional service. Locally, we've got loads of examples of good provision. So Leeds Dad, some of the other family support. Within Leeds, we've got a super specialist substance misuse service as part of the addiction service. The challenge is when you're repatriating women and families back further afield, they don't always have access to the same. So it really raises this inequity issue across bigger geographies when you do have these specialist centres. So the flip of my question is, I could list loads of great stuff that we've got within West Yorkshire, but we've still got a big gap, haven't we? We've still got a challenge in terms of the outcomes for mums and babies. So is there anything that we've missed a trick on that other places are doing? Because I don't know what other great services or initiatives other parts of the country have got. So is there something that we could learn from elsewhere, or some of the things within here that discussion earlier, that has a bigger impact than others? It's that really making sure that the stuff that we put our time and resources in for these women and the babies and their families has the biggest impact. And is there evidence to tell us what that is, notwithstanding, some of the broader public health stuff around smoking and obesity and housing and so on?
Sarah Smith, do you want to just come back on that, and then we'll go to our next round of comments and questions?
Yeah, I will do, and I may bring in Debbie as a maternity expert, I think, but certainly that's why we picked up the early booking element of the pathway specifically, because we know if we get people on the maternity pathways earlier, the outcomes are better. So that was one of the specific things. But in terms of learning from other systems, Debbie, I don't know if you want to add anything.
Yes, I think it's a challenge across the country to varying degrees, depending on the levels of deprivation in particular populations. But I'm not aware particularly of anywhere that's absolutely got it right at the moment. I think we're all learning from each other. We do have really good working relationships with other ICB footprints across our region, and we do sort of share particular initiatives, and we know that certainly like the consultant midwives that we've got, the lead on health equity within our system, do work with other places just to find out what that learning is, and I think we're still learning. We're still doing lots of things. We absolutely know that having that relationship care really makes a difference. We know that if women know their midwife and they see their midwife regularly and get the care that they need, their outcomes are improved. So a lot of the initiatives that are around focusing on that, and then it's about actually measuring that impact. And again, it's not just about the outcome, it's about that overall experience as well. So.
Thank you, Sarah and Debbie. Okay, we're going to go to the next set of comments. So AC, then Richard, then Kate, and Fatima, Hannah.
Thanks, Kathy. I'm Rancho Chatterjee, non-exec member of the board. Again, thanks a lot for the report, and quite a bit of has been sort of captured in terms of observation. I've a sort of observation and a question. I was involved with the Women's Digital Care Record Evaluation pre-pandemic, and quite a few of the points that we are touching upon was part of that sort of process evaluation in terms of service reconfiguration and things that sort of come out of this report. So really, firstly, it's a great progress, something that we started together. And I remember when I joined the board, we had this conversation, Kathy, in terms of looking at a matrix of outcomes and how various strategies touch upon some of them. So this is a good evidence showing that some of them are making real progress and we are actually improving the service as a whole. There's still lots to do in terms of plugging those gaps, and I think some suggestions have been made there, both from Health Watch as well as the service report itself. So the request was to think about some, I think Majid also highlighted this, quite a few common themes have evolved from the Health Watch reports over the last few months, as we have seen in terms of the deep dives. So it will be useful to see how we are responding in terms of communication, access to various services, which the places can take ownership of and crisscross across the implementation of a number of these key clinical areas. There's also some sort of data around that. If you think about the obesity data as well as the folic acid the folic acid consumption data, there's quite a bit of variance in that. So it will be useful to firstly understand why that sort of Wakefield is, for example, quite low in that, even though there is deprivation cited. But is there any sort of work that's been done to try and understand that pattern, and again linking with, for example, the obesity strategy has that sort of obesity map layered over multiple conditions and feeding crisscrossing. So we are referencing here, is the obesity strategy referencing that's a key outcome as well. So it will be useful to review that at some point.
AC, I think that's really, really helpful. Thank you. And as you were talking things through, I think there's a role that your transformation committee can play in looking at new ways of working, particularly as we look at ensuring effective hospital services, as well as looking at the integrated neighbourhood team blueprint. And also today, unfortunately, our colleague Nadra Mirza, who chairs our quality committee and is our non-exec for maternity safety, I think there's something we can talk through with her, as well as working with colleagues around the table. Thank you. That's really helpful. We'll go to Richard and then we'll go to Kate.
Thank you. I'm Richard Vautry, GP in Leeds and the Primary Medical Services representative on the board. Thank you very much for the report. I really support all of the recommendations and the themes that go behind it. I think there's a lot that we need to do. Anyway, it's just picked up a little bit from what AC just mentioned. I was really struck by the variation on folic acid uptake. I mean, I think that's the starkest within West Yorkshire, sort of the variations, where you've got something like just around 3% sort of women in, I think it's Wakefield, taking folic acid sort of before pregnancy, sort of up to well over 20% sort of in Bradford. Why is that? What's happening around that? And what can we do to actually make a real difference around that? Alerting young girls and women sort of around sort of the need and importance of this, and doing some education around that. But I wonder whether there's something as an ICB we can do to really back up the government's agenda around fortification of folic acid and flour with folic acid. I know that they're committed to it, but I don't think they've done it yet. So I think what can we do to push that agenda on, because it would make a difference to our population, not just women, but as a GP, every week I'm issuing prescriptions for folic acid because large numbers of people have a folic acid blood test and find themselves quite deficient, and that's very, very prevalent in our area. So I think there's much work we can do around this, and it would make a difference, and it's quite easy to tackle.
Richard, thank you very much. A call to action there, complementing what AC has shared. So sometimes what comes out of these meetings are things we want to take to a regional or a national level, and perhaps it is influencing even government policy. So I think I'm looking to Rob and Ian alongside myself to take that away to explore. Sarah and Debbie, I don't know if there's any comment there, particularly on the folic acid intake. We've got two board members here who are really interested in what we can do to improve. And I know there's another GP around the table who may have a similar experience as well.
I'm looking to Victoria as well, because I think it's something that falls in that sort of preconception space between local authority and wider public health and role of the ICB in local maternity system. So it might be one of those spaces where it's joining up the system dots, really, to find out what's happening in the different areas. So I don't know if there's any areas of good practice that are happening in local authorities that we can learn from on that preconception space and take into the local maternity system.
So I can see Victoria nodding. James, do you want to come in as our medical director for the system?
Yeah, I absolutely think we need to pick up on that and understand a bit more. I just wonder, and I'm just thinking in terms of the figures we see highlighted in terms of difference between Wakefield and Bradford, and whilst we've all got a born-in Wakefield, Bradford, born in Bradford have highlighted very much preconception and advice and support there, and I just wonder whether there's something sits behind that we need to kind of understand to take forward. So I think that's kind of one area that kind of springs to mind in terms of where we look. I do know all our places now have a born-in, and therefore I think it's kind of we need to kind of pick it up and see what we're doing in other places that might link in with that. But it's probably wider than that, but that may be one place to start.
Okay, thank you very much, and thank you for those comments. So we'll now go to Kate, then Fatima, then Hannah.
No, thanks, Cathy. As you say, I think there's been several references in both reports to workforce. So thank you first. And I think, like most people, I agree with all of the recommendations. I'd probably group this into two areas. One is that education and training of the workforce, and I think particularly that reference, Hannah, in your report to sort of cultural competence and awareness, and certainly I'd like to explore perhaps with colleagues like Debbie and others, what is there available at the moment. There will be some great training happening, I know, but to really understand a little bit more in terms of that space. I think the other thing, Chair, is around the second, or one of your recommendations, Hannah, around representation within the maternity services, which I think is very much aligned to something you said, Fatima, that whole piece around understanding our patients and ensuring that we are representative within our workforce. It goes back to perhaps the first point I made in the board today. We have a really successful, inclusive recruitment approach, and perhaps that's again something I can explore with colleagues within the maternity services to say how are we utilising that, and is that something that could perhaps see an impact, I think, from a positive perspective. But thank you all.
Thank you, Kate. That's really helpful. Hannah. Oh, sorry, Fatima, then Hannah. Sorry, wrong order. Sorry, Fatima.
It's all right, Hannah. I'll be your warm-up act.
There you go.
Well, actually, I did want to say something to Hannah, which is I really think it's important that we acknowledge and thank all the women that shared their stories. I was quite triggered reading the report as an Asian woman that's had 2 kids. Both of which were not great experiences. They do stay with you for a really long time. I'm not going to tell you how old my kids are because that would give away my age. But it does stay with you. It really, really does. And I think that there are a number of opportunities of which we can take from this. The first is there are some really great examples of good practice. What I'm really interested in is what can we scale up quite quickly. The second thing is the element of trust. So how do we reassure women like me that if I'm having a baby right now, that I can go into a hospital and have a really good experience? And I think there's something about how we use the VCSE Voices panel that are really chomping at the bit to support this, to help with some of those solutions and create some people that are pivotal within our communities to reassure people that it's okay, but also to work with our practitioners on some of that cultural competence training that Kate alluded to. I think the other thing is we have got an incredible programme of personalised care within our system. If we get that right, that will address some of these areas that are manifesting about people taking folic acid, about access to services. And I think also, Sarah, as sort of the SRO for Inclusion Health, I think there's some really great stuff we could take into that conversation about how we support, prison leavers, sex workers, asylum seekers with their access to services too. So I suppose what I'm saying is that there are a number of things that we can lift and shift, but we can't ignore the fact that we're in a context where our services are more pressurised now than ever. So how do we support our staff who are already really busy and time pressured to have the bandwidth and space to adopt some of this? And also to widen the approach, because some of this stuff can be done outside the hospital, but how do we bring people with us to deliver some of the stuff we need to deliver from a care perspective, but in a less paternalistic way and a personalised way with people that already exist and want to help?
Thank you, Fatima. That's really helpful. And your point about people having choice is also their choice of place of birth, isn't it, as well, which is key. Hannah, do you want to come in there?
Yeah, just a couple of reflections, and just to, I hope I said it right at the beginning, but like Fatima says, big thank you to the people that shared their experiences here, not just to us, but to the Mental Maternity Voices Partnership and all the different spaces West Yorkshire voiced, totally. And I think just reflecting on some of the key messages that people shared with us around the EDI strategy as well is, people don't just want to share their experiences, they want to see stuff happen as a result of it. And I suppose that goes on to the point that AC made and Majid made around some of these themes that have come out of our reports are they're recurring themes. And how do we move to that space where it is around action? And actually, Rob, you asked a question about people ask you, what can you do about inequality? Some of this stuff actually is quite simple, and to use Majid's words, it's getting the basics right. It's about good information, it's about communication, it's about time to ask questions. It's around listening to people. And so I'd be really keen to maybe use this report particularly as an example of how do we move forward around that. This is what people have said, what are we going to do as a result? There are some really hard-hitting messages within this report, particularly around racism, around not being listened to. So I really encourage us to think, right, okay, we've heard it, what will happen as a result of it?
Thank you, Hannah. And that's why Sarah Smith is very keen to come back to us within a matter of weeks to share what's happened so far. And I think also I encourage board oversight of this over the next 12 months or so, that we all agreed to this, we've signed it off, what has happened so far and what's still to be done, so you can hold this work to account. So thank you, Hannah. And I know you want the West Yorkshire Voice Forum also to be very much involved in this in holding us to account. I'm going to take chair's privilege here. I've got some questions, one on our progress with women's health hubs, and secondly, our work on housing and tackling fuel poverty, which is so one very NHS kind of question, and one on how we work together as a system. So I don't know if anyone can help me. First of all, our progress on women's health hubs, and then secondly, on what we're working together on fuel poverty. I partially know the answer to that, but I'd really welcome board members around the table hearing that. I don't know if Phil Hubbard might be able to help me with that on women's health hubs.
Keep having to just check. Yes,
and then come to Debbie if that would be really helpful. Thanks.
Yeah. So just in regards to women's health hubs, I mean, this is an area where you really kind of focus, and it goes back to the point that we were just making about maternity preconception and actually having conversations about how it does feel to actually be working having a birth within our environments. And I think it builds on the points that have already been made about that health inequalities and the housing and the estates and how it feels to work within that. So the health hubs have been a real key focus area. I think there's more we can do, if I'm being honest, around really thinking about that preconception support. So I know we've got some great areas of good practice, but there's still more work to do about learning from that and about the experiences of individuals as well. And just sharing what you've just shared now, Fatima, I think a lot of people would still say that feels the same, and that's really quite evident in the health inequalities from Health Watch. So there is more work that needs to be done, but I do honestly believe that we are making inroads in there now, and we're beginning to see a real difference about bringing individuals together to share that experience as well.
Thank you, Phil. James?
Yeah, just to build on what Phil has said in terms of women's health hubs, so we have developed those across West Yorkshire in our different places, and they go through maternity, whether the maternity services, but also in terms of looking at the menopause, looking at HRT, and also looking at other conditions, kind of endometriosis as well. Very much focused in some of our places around our integrated neighbourhood teams. I'm working with our PCNs. I work within a PCN that is working with our local trust to help support delivering some of those services within some of the kind of most deprived areas as well there. So there's a variety of them, depending on the needs of our communities and our different places, that these health hubs are developing across all ages.
That's a really helpful update, thank you. My second question was around tackling fuel poverty, and I know Sarah, Victoria and others of us had a conversation a few weeks ago about this, because we can see the rates of fuel poverty in West Yorkshire rising above the national average and rising above our neighbours in other parts of the north of England. I don't know if there's any reflections there, Sarah, Smith and Victoria, and then I know we want to then hear from Rob and then we'll finish up on this item. But just that point on fuel poverty, it's through this lens of maternity services, but it's an issue for our communities at the moment.
I think a couple of reflections, opportunities. I think one's around influence. So our role as an ICB board representing the health and care system to influence the combined authority for this cohort and the impact of fuel poverty for this cohort. So sharing some of this intelligence, I think could be really key. And I think the other element is sort of what do we do about it then as a health and care system? And we've got some really good examples of good practice where, for example, in Pinderfields, where they appointed a housing discharge facilitators, and that's been reviewed by the University of Sheffield as kind of a successful model. I think that was for adults rather than maternity, but that's a worked through model that we could implement for maternity services, and that's looking where housing's a barrier to discharge, and you would think, again, for this cohort, fuel poverty might be there. So there's some practical things we can do as well as some things we can influence as a board on this.
Thank you, Victoria, and then Fatima.
Hi, thank you, Chair. Just to add briefly, on the issue around housing and health more broadly, it's such a significant public health issue. I mean, clearly that cuts across everything we do. So just speaking for a second from a Leeds place perspective, as people are well aware, we've committed to becoming a marmot place and addressing the social determinants of health, and our two initial priorities are around housing and health and 0 to 5. So there's a huge amount of work going on in that housing and health space more generally around a major driver of poor health, what we can do about it, and I guess in essence bringing housing professionals and that whole sector together with healthcare professionals and creating better understanding and links between the two. All sorts of work going on in that space. But specifically also within the 0 to 5 priority, housing for this cohort of families is also coming up as a real priority around making sure that people get the right support and advice. So there is a lot happening in both those spaces that I think the challenge is about scale and scaling up and joining up that work. So really up for doing more of that. And I think specifically we have some quite small pilots around heating on prescription for groups that are clinically vulnerable that actually fully engage healthcare practitioners in the prescribing bit, and then people are supported to keep their houses warm, and then that is good for them and it reduces avoidable appointments. Now that's been funded creatively through the Household Support Fund, which comes into councils, and so there's some interesting work around resource that's going on there, which goes beyond NHS resource. Again, that works pretty small scale with a couple of PCNs. So again, it's looking at how we can scale some of that work up. But hopefully that's helpful. Thank you.
Thanks, Victoria. I think this is helpful. As you know, we've had our place partnership arrangements reviewed quite rightly over a matter of years. We want to see what's working, what we can learn on, what we can develop. And I think that's an example there where housing and health can come together through our place partnerships and bringing providers closer together. Fatima, did you want to comment on that? And then we'll go to Rob.
Not comment, just volunteer for two actions. So one is the Mayor has a fund, a poverty fund. I will go away and have a look at the criteria and see if we can strengthen that in this space. The second one is I will take an action to share this data with the housing team to see if there's more we can do in that space.
That's great, and I'll support that, particularly as a member of the West Yorkshire Combined Authority Places, Regeneration and Housing Committee, working with Jennifer Connolly. I'm really pleased I remember the entire title of that committee. And this is where I'm picking up a lot of fuel poverty information, because it's a really positive thing that the NHS is working with the Combined Authority on that. Rob, do you have any sort of final thoughts, and then we'll go back to Joe, Debbie and Sarah?
Well, some thoughts and a question. Something that hasn't come up really. So I think generally this is such a good report on so many fronts, and this conversation's been a really strong demonstration of the actions that we're taking on what is one of our 10 big ambitions as a partnership. And it's really good to see the progress. And at the same time, this is a shocking report, isn't it, into some of the inequities faced by women and their families in West Yorkshire when it comes to mortality and of neonates and mums. And we know that, so that's from a population basis, and we also know that service-wise there's more to do in terms of quality. Right across the country, maternity services, I think, are the biggest area of clinical negligence claims, aren't they? And when this goes wrong, it has lifelong consequences, not just for individuals, but for their families too. So we're doing brilliant work, but there's so much more that has to be done. And I was really struck by two things here, and I've got a question. So first thing is the point about the basics. And I was, really struck by it. This isn't some elements of this aren't about some significant technological intervention that's going to cost us a fortune. It's about staffing and skills and communication, getting the basics right. Now, that sounds easy, but it's not. And what I really liked in the paper was some of the responses in places to those issues. So I'm just reading here, just to remind you, in Leeds, 27% of bookings, English is not the first language. And of these, over 9%, nearly 1 in 10 women need an interpreter for 59 different languages. So getting the basics right might sound straightforward, but it's not. Now, the second thing I'd say is that some of the responses here to getting the basics right, to doing the right thing, having continuous conversations with people, building in longer consultations for people who live in poorer communities, who have more complex issues going on in their lives, etc., it's less productive than the average. So if we want to do this in an era of productivity, when we're looking at benchmarks, we have to be really careful. Because we might not be able to deliver a productive individual consultation, but we might be able to produce a much more productive population intervention, which in the round costs less and has better outcomes. So we've got to be really thoughtful. That's another strategic commissioning conversation, I think. And then the third thing that prompted me to think about, we haven't talked about, is technology and AI. So with the development of technology and translation services, etc., and AI, have we got any, for the main languages, are there technologies that we can use to take women through their pregnancy with us? I've seen apps that do that. I don't know if they're any good, but are we doing any assessment of that? And what about all the technology that there is now around translation, and whether that allows us to do things fundamentally differently and better in this space? And maybe Shaukat's group could have a look at that. Yeah. Because that would help with productivity.
It would. The theme of the year. Okay, Shaukat, we leave that with you to consider.
Yeah, I think there's a lot of potential, and then we have an AI steering group that has just started its working, and then these use cases we are picking and then working on those to find the solutions. Thank you.
So I hope this report's helpful to you then in looking at that. Thank you. I'm really pleased that every time we have these sessions, action immediately happens, as well as considered thought. And I know people go away and take this into their own work, which is really helpful. But Hannah, it's quite rightly, you should challenge us. What's the impact of this? What is going to change in general? So Sarah, Jo and Debbie, is there anything you want to reflect on or take away or any asks to the board?
I'll just reflect on some of the key points. I'll keep it brief because I know we've done a lot of reflection throughout. So I think we're definitely hearing something about cultural competence and people feeling heard is the main thing from that. So, and whether we do that through training and also through workforce representation, we've heard as well. There's some real opportunities around determinants of health, and I think we've made a commitment to make some connections there. But also some opportunities for us to act on those within the NHS, whether that's within trusts or through integrated neighbourhood health development. there's some opportunities with the digital and data strategy, both from an AI point of view, and would really welcome some public health representation on that AI group. Joe Katz will be in contact. I think it'd be really good to kind of explicitly make some connections there, as well as through an intelligence point of view on this stuff, so we can target interventions. And then I think finally just those, for us to keep doing the targeted prevention work that we know works and keep doing that well. So whether that's smoking, support with healthy waste and obesity, and then we've picked up a point here around folic acid that I think we could sort of build on as a system. So I think there were some of the key points that we've heard that we'll add to the recommendations and take away. Debbie, was there anything, or Joe?
Yeah, I think to add on to that, communication is the key thing. I think looking at some of the pathways that are already in place about ensuring that women have additional time with their health professionals to be able to build those relationships, to be able to articulate what they need, but to actually learn what is available to them, I think is really key. We know, as Rob said, the translation services, it's not a quick fix, it's really complex, but actually what can we do? And again, I welcome being part of, having maternity on that AI that group. We've already had some midwives in Harrogate looking at that and been doing a bit of a test of some videos that we already do for women and using an AI app as a bit of a trial. So I think there's a real appetite there to do something different. We have an app available for women with pelvic health problems. We have that translatable in multiple different languages. So there are things happening there. And I think the other element that I just want to reflect was about that workforce. I think there's absolutely a lot of training and things we can do. Some things that will take a fairly quick, some that are a bit medium term, but actually we're looking long term, looking at growing our local populations, and we're already starting to think about looking at our future midwives, not the ones that are training now, looking at those doing A-levels now, what are their plans for the future, looking at those that live in West Yorkshire and then want to work in West Yorkshire, supporting them and ensuring that our future workforce represents all our populations.
Debbie, thank you so much. Shaukat, you've got a really good working group going there now, which is great.
Yeah, a couple of use cases, so that's really good. Thanks.
Great. Okay, thank you very much. So as a board, we note the progress with tobacco dependency services in West Yorkshire. We support quality improvement interventions, particularly for those living in the most deprived areas, and supporting our diverse communities. Continue to endorse raising awareness of perinatal mental health, maternity health and risks, and the support that's available that is culturally sensitive. And we support the alignment with the recommendations to the West Yorkshire Race Equity Review and the related strategy. Colleagues, are you in agreement to support that? Thank you. I really encourage you to take this back into your organisations, this report, into your provider collaboratives and into your place discussions. I think this is really helpful. And I'm always very pleased in our board meetings where we have something to take out in terms of influencing or even lobbying outside of our system as well. Thank you very much. AC.
Thanks, Kathy. Absolutely, I agree to this. And just a general reflection, we had this was a final deep dive for this year, effectively. It might be useful to summarize sort of over a couple of A4 pages, so what conversation, and then perhaps share as a follow-up in terms of what we have learned and what we are taking forward and how we are taking forward in various aspects of common themes, but specific themes as well that we have picked up. So a follow-through circulation would be really helpful.
Thank you very much, AC, and I'm nodding because Sarah Smith already has offered to do that for us, which is great. We'll link that with our April board development session. And colleagues, as you know, this is my last board meeting in public, though I'm around for a good few months before I move on. So I'm really pleased that I've seen through this conclusion of looking at these focus on sessions. But as I said to Sarah when we spoke about this a year ago, this is the beginning of the work, and this is at least 2 years of working together as a board and a system on this. So I hand this over to you all to carry on for the next 12 months at least. So, but thank you, AC. Something really practical, 4-page summary, the live course approach on our focus on sessions, I think would be really helpful. Thank you, everybody, for your contributions to this discussion. We're going to take a break now and then come back to part 2 of our meeting. Sarah, Joe, Debbie, others, Victoria particularly, thank you very much for your contributions. And we will pick up again on the quality of maternity services in our system at our June board meeting. Thank you, and we'll take a break now.